1. Hello, my name is Seth K from the Center for Thyroid and Parathyroid Surgery, and in this video we will be discussing a total thyroidectomy. A total thyroidectomy is a surgery to remove the entire thyroid gland. Reasons to perform a total thyroidectomy are for enlarging benign or non-cancerous thyroid nodules, enlarging goiter, or the entire thyroid gland is enlarged, for thyroid cancer, and sometimes for overactive thyroid glands. That could be Graves' disease or multiple toxic thyroid nodules. We do not carve out nodules or disease in the thyroid gland in order to preserve thyroid function. The reason being, if we try to carve out diseased thyroid nodules, there's a high chance we can leave something behind, and you would require a second stage surgery to remove it, which is highly complicated with much higher risk. So our guidelines from the American Thyroid Association recommend that we remove the entire thyroid gland if it's indicated. So a total thyroidectomy is performed under general anesthesia in the operating room. That means you get an IV medicine that goes through the IV and you go completely asleep. Once you're asleep, we put a breathing tube down the windpipe to breathe for you. I use a special type of breathing tube that allows me to monitor the nerves, your vocal cords, and I'll explain why that's important in a little bit. I make an incision low in your neck in a natural horizontal crease. I do specialize in minimally invasive procedures, which means making the smallest incision possible in order to get out the thyroid gland safely. Now, typically the thyroid lobes, or one side of the thyroid, measures about 4 to 6 centimeters, and I can make about a 5 centimeter incision in the midline, which allows me to remove both sides of the thyroid. Now, if your thyroid gland is bigger, or if you have a large neck, sometimes that incision needs to be a little bit bigger. In order to remove the thyroid, it takes about 2 hours. Once I'm finished, I close the incision with a few stitches that go beneath the skin, which will dissolve on their own. On top will be blue skin glue and white bandages embedded in the skin glue. The nice thing about this type of bandage is you can get it wet. So that night or the next day, you can take a shower, just let soap and water run over the bandage, no scrubbing, pat it gently dry with a towel. This bandage stays in place for 2 weeks. If it's on any longer, you peel it off. So very simple and easy to take care of. Sometimes the bandage falls off before 2 weeks, not a big deal, you just leave it be. Once the bandage is off, you can scrub the area like normal. You'll also notice a few bumps along the incision line. Those bumps are the deep stitches that haven't dissolved yet. I promise you with time, those bumps will go away. I do ask that you take it easy for 1 week, avoiding any strenuous activities that would elevate your heart rate or blood pressure and increase the risk for bleeding inside the wound. That means no running, no jumping, no lifting heavier than 10 pounds. After 1 week, there are no restrictions. You can do whatever you like. There are no restrictions in the position of your head and neck following the surgery, so you can sleep and relax in whatever position you like, including the first night of the surgery. You will expect to have a hoarse voice. Despite that, there are no speaking restrictions, so you can talk as much as you like. That hoarse voice can take up to about a week. You will have a sore throat as well. For that reason, I do recommend starting on liquids and soft foods. You can go to solid foods as soon as you tolerate. That may take about 1 to 3 days. Pain and discomfort in the incision in your throat can last up to about a week. Usually that's well controlled on Tylenol and ibuprofen, which you can alternate between, as well as ice packs and sore throat lozenges. I do send you home with several low-dose narcotic pain medications just in case you need something stronger. If you do, it's usually just the first night, possibly into the second day as well. Usually not much longer than that. I do also send you a prescription for an anti-nausea medication. This is a tablet that dissolves underneath the tongue. Sometimes general anesthesia can cause nausea and vomiting, and I don't want you throwing up afterwards during the recovery period. Number one, that's a miserable experience. Number two, it also increases the risk for bleeding inside the neck. So if you're nauseous, please have a low threshold to use that anti-nausea medication. Because we're removing the entire thyroid gland, we will have to replace the hormone that the thyroid makes with a once daily thyroid hormone medication you take for the rest of your life. I estimate that dose based on your weight. When you follow up in the office 6 weeks later, we get blood work just before that appointment to measure where your thyroid hormone levels are at. Sometimes we have to make an adjustment or two to get you in the perfect range. I also ask you to take an over-the-counter calcium supplement for a 3-week period following your surgery. Your parathyroid glands, which are next to the thyroid gland and control your calcium levels in the body, are very important. And if I do a good job of preserving those parathyroid glands, not removing them, sometimes they can be temporarily stunned, and you're at risk of having temporary low calcium. For that reason, that's why I ask you to take those calcium supplements. A normal calcium tablet or pill is usually quite large, a horse pill, and that is difficult to swallow when you have a sore throat. So I do recommend you pick up a chewable calcium supplement, either in gummy form or a chewable tablet like Tums. I do want you to be looking out for signs and symptoms of low calcium, which would include numbness and tingling in your lips and fingertips, or cramping in the hands or feet. It's a sign that your calcium levels are low despite the calcium supplement. Please call the office if that's going on. We will instruct you on what to do following that. The 3 prescriptions would be sent electronically to your pharmacy that's on file, and you can pick those up on the way home from the surgery. And going back to activity restrictions, you can drive once you're off the strong pain medication, and once you can turn your head and neck to check your blind spots without hesitating. That's about 1 to 3 days. So essentially, I'm asking you to take it easy for 1 week. You can still do things around the house. You don't have to be bed bound. You can go up and down stairs so long as you're doing slowly and carefully. You can even run errands once it's safe for you to drive. I typically recommend about 1 week off of work, sometimes 2 if you're working in manual labor, doing lots of heavy lifting. So that's the surgery, and that's what the recovery is like. Next are the risks. So with any surgery, there are risks. The one specific to this is injury to some nearby structures in the neck. The first being the recurrent laryngeal nerve. This nerve runs right behind the thyroid gland on both sides, and it controls the movement of your vocal cords and your voice. So it's very important that I find this nerve and protect it throughout the surgery. That being said, sometimes the nerve can be stretched or over-manipulated, and that can result in a temporary weak or hoarse voice that can last several days, sometimes up to 9 months. So that's about a 5% chance for a temporary weak or hoarse voice. There is a 1% chance that nerve can be severely damaged and never recover. In this situation, it could result in a permanently weak and hoarse voice. Now, this is very rare. It only happens about 1% of the time. If it were to happen, there is a second surgery that could be performed at a later date and time to help bring that voice back to pretty close to normal. Conversational voice would be the same, but singing and yelling would always be off just a little bit. So not the end of the world if that were to happen, but certainly a major inconvenience to go through that process to get the voice back. Now, the risk for injury to a nerve does go up slightly higher the larger your thyroid gland is. If you have a goiter that's extending into the chest, which we call a substernal goiter, or aggressive thyroid cancers, that risk to nerve injury can go up a little bit higher. There is an accessory nerve to your voice box called the superior laryngeal nerve. This nerve controls specifically pitch and projection of your voice. There is a 10% chance that you could have temporary injury to this nerve and have temporary changes in your pitch and projection lasting to about 9 months, a 5% chance that it could be permanent. Now, the first nerve we talked about, the recurrent laryngeal nerve, which controls the bulk of the movement of your vocal cords and your voice, is injured on both sides. It's a much bigger deal. If that were to happen, you could potentially have difficulty breathing and the need for something called a tracheotomy tube in your neck, which could be temporary or sometimes even permanent. Now, I don't want you to have a tracheotomy tube under any circumstance. If you think back to the beginning of this surgery, the breathing tube I use as a specialized one. It allows me to monitor this nerve during the surgery. So after I finish on the first side of the thyroid, but before I proceed to the other side, I will test the nerve on the side I was just working on. As long as it stimulates appropriately, indicating that the nerve is working, it's safe to continue the surgery. But if it did not stimulate, then I would only remove that one half of the thyroid, leave the other half in place, close the incision and wake you up, and wait for that nerve to recover before bringing you back for a second stage surgery. While a 2-stage surgery is not ideal, it's much better than putting you at risk of needing a tracheotomy tube. Next to the risk to injury is something called the parathyroid glands, which I mentioned earlier. You have 4 of these. They're very small, like the size of a rice grain. They sit on the surface of the thyroid. They're very important in that they control calcium levels in your body. So during the surgery, I need to find these tiny parathyroid glands and gently sweep them off the surface of the thyroid. being said, sometimes they're so small they're accidentally removed, and they're so delicate that they can be injured while being manipulated. Thankfully, you only need 1 out of the 4 parathyroid glands to have normal calcium levels following the surgery. However, if all 4 are removed or accidentally injured, that could result in permanently low calcium levels. You'd have to be on calcium supplements every day for the rest of your life, sometimes 2 to 3 times a day, which is very inconvenient. Thankfully, the risk for this is low. It's 2%. That risk is increased when you have Graves' disease that's causing hyperthyroidism, and sometimes if you have Hashimoto's thyroiditis. Next to the risk of any surgery, that includes infection. That risk is very low, 1% or less with this surgery. Signs of infection would be redness, swelling, pain. You do get antibiotics at the time of surgery, don't need anything else afterwards. Risk of bleeding is low, so long as you're not on any blood thinners. That risk is about 1%. Sometimes one of the blood vessels I have to seal off in order to remove the thyroid could open up afterwards, and that would result in bleeding in your neck, which you would notice as swelling like a bullfrog. Sometimes that bleeding stops on its own, sometimes it does not. I have to bring you back to the operating room urgently to stop that bleeding because it can be life-threatening. Thankfully, again, the risk for this is low, 1%. It's also the reason why I ask you to take it easy for 1 week. It takes an entire week for that blood vessel to completely seal off, and I don't want your heart rate or blood pressure up during that period where it could open up before it's completely sealed off. Next is the risk of general anesthesia. Usually that risk is fairly low. If you have, we do require, that you get cleared from your primary care doctor with a routine physical. If you have any other significant health problems with your heart or lungs, we may ask you to see that specific specialist to clear you as well. Lastly is the risk of a scar. As I mentioned, I try to keep it as small as possible, hide it in a natural crease. Ultimately, it's up to your body and how you heal. So long as you don't have a history of keloids or hypertrophic scarring, usually this incision heals very nicely. I performed the surgery at Central DuPage Hospital, and that concludes our video on total thyroidectomy. If you have any other questions on total thyroidectomy or any other topics on the thyroid or parathyroid glands, please visit my website at sethkaymd.com. That's SETHKAYMD.com. Thank you very much for watching the video.